I think kind of touched me a lot. This was a young girl who first got diagnosed at the age of 17 with a tumor which was excised somewhere, and they told her it was benign, and she kept on having recurrent tumor. Long story, multiple resections of recurrent liposarcomas and radiation therapy. And 10 years down the line, when she was tumor free, this is what she looked like. She wanted to be a nurse. She wanted to go back to society, be an active member. She really wanted to talk to people and say that, hey, look, I've survived. But she also had this issue with, low self-esteem, looking like what she was, because she never had any rehab. So we tried to figure out what all issues she has, apart from the soft tissue defects and all. She had this poor dentition because she couldn't open her mouth. Her teeth were all crooked and all over the place. Her teeth wouldn't bite properly, which as a dentist was a very jarring thing for me to see. So she would be on soft diet despite having good complement of teeth. So we had a good, and this case took us almost back and forth discussion with the plastic surgeon, with our maxfac surgeons, with the prosthodontist as to what we can offer. And we identified few issues. Apart from the scar and soft tissue defect, this patient didn't have a good mandible, and her maxilla, due to the radiation and everything, had grown in a very canted manner. So we realized what all had to be corrected. We did a reconstruction with the fibula, but we also did a maxillary rapid palatal expansion at the same setting. And this is what we were able to achieve. This is what her teeth look like. This is her with the maxillary teeth are well aligned with the orthodontist. And post-op bony reconstruction, all done in Marseille. Her looks have improved very much, and she's now a nurse in our department, actually. Well, of course, she does require a little bit of small things here and there, but like fat graft cells, but she is doing pretty good. In this case, that had recurrence, had a fibula done, and this fibula had infection and died off. And sometimes you take risks. You look at this kind of cases, it's like this patient doesn't want another fibula done. But of course, I can't rehabilitate a single sort of a medial plate of small fibula bone that's lying over there. So you go back to your basics and take a bit of a bold step. You take your hip graft, but then you add on all, like my colleagues say, all the good stuff from your blood. So you get your PRP, and you put your bone there with PRP, with calcium chloride, and that promotes very good healing. And this patient had a good fibula and is going to be ready for rehabilitation with implants in a couple of months' time. But sometimes less is more, and you don't do too much. You don't go all the way. So this is a patient who had recurrent buccal tumor. At one point, she had a tumor that started invading into her mandible. So after buccal-wide excision, she had mandibulectomy, and then she didn't want any sort of reconstruction from a fibula. And so we decided, okay, if she doesn't want, her mandible's going to swing, and we can't allow that because then she's not going to be able to eat. And she's a pretty young lady. So we decided to speak to our orthodontist and prosthodontist to devise this particular device. I'm not sure if this works, but there you go. You teach her how to use this device, use elastic rubber bands to just train her jaw. And who would have thought that a mandibulectomy patient post-resection can still able to function quite well? So this is her, and that picture of her at the very far right is her 6 months down the road. Good occlusion, still able to eat, no facial asymmetry. So sometimes you just have to take a step back and say, is there something simpler that I can do and get away with? All right. So in the interest of time, we'll just go to summary. Well, you do require surgical reconstruction, especially in cases that have massive recurrences and have a very huge defect. What is critical is that they need rehab, not only just at that point, but it's a sustained effort. So you need to continue helping them with their rehabilitation efforts on a long journey. And it's very important to have a multidisciplinary team. So this is our team, which is composed of National Dental Center, Head and Neck Cancer Center, Cancer Center of Singapore. We've got the head and neck surgeons, the plastic surgeons, the prosthodontists, the maxfac surgeons, and we have a very, very good allied health team, and that kind of helps our those poor recurrence patients to kind of continue with this journey and integrate back into a good quality of life. Thanks.
Thank you so much. So we have a lot of questions, but I think we have to keep it for the end because we are running late for the session. So I invite the next person, Dr. Simon, to speak for he'll be speaking of recurrent thyroid cancers.
I will be talking about prostate cancer and non-surgical cases. I will emphasize instead I think of as my guide to differentiate thyroid cancer, especially in light of the recent APA 2025 guidelines and what wisdoms they bring to our practice. So differentiated thyroid cancer, as you know, is a papillary thyroid and follicular thyroid carcinoma and represents almost all of the thyroid cancers that we see. Majority of them are diagnosed in the early phase, but there is a small proportion that does progress to recurrence, and the ones that we would like to focus on today. So 88% of those recurrences take place in the initial 10 years, and the majority, or more than 50%, in the initial 3 to 5 years. Recurrence is thought to be or represent remnant disease, which has reached the threshold of detection, meaning it has been there since the initial surgery, initial treatment, but has now come to the surface. And of course, can be either local, regional, or distant. So as I see those patients, I ask myself these real-life questions, and I think this is how I frame my talk. I think the theme of many talks in this conference and otherwise is that sometimes less is more. And finally, what is the optimal type of intervention for the patient? So I'll start with number one. And the initial treatment, of course, is important because prevention is better than cure, prevention of recurrence. And appropriate surgery remains first line. Total thyroidectomy and unilateral lobectomy are the standard of care in lowest patients, with neck dissection being considered for certain high-risk features. For example, any gross extraocular extension for T2 tumors, known lateral neck disease, clinical N1B, or aggressive histology, for example, Tulsa subtype, Hobnail, or diffuse sclerosis subtype of PBC, as well as the more modern approach to molecular analysis, BRF600E combined with a TERT promoter or a P50 mutation will contribute to this high-risk profile that would suggest that a neck dissection should be done in a prophylactic setting. Of course, for clinically no negative central compartment disease, therapeutic neck dissection is indicated, and lateral neck dissection is reserved for clinically no positive nodes in the lateral neck itself. So, subsequent to surgery, you always ask yourself to RAI, not to RAI. And more recently, we have accepted that routine RAI ablation is discouraged, and the APA 2025 guidelines emphasize what they call purpose-based RAI, right? So we can divide it into 3 different subtypes. First one is ablative, which aims to eliminate remnant tissue to facilitate surveillance in low-risk diseases. Adjuvant, where we destroy suspected by microscopic residual disease. And therapeutic RAI, which is used to treat known residual, recurrent, or metastatic disease. So the intent, the disease burden of the patient, as well as patient factors, very importantly, inform the RAI dose. So how do I decide? And this is where this new data framework comes in, which is a framework for dynamic risk stratification. So data is an acronym, diagnosis, assessment, treatment, and then reassessment in a cyclical kind of pattern that allows us to decide what is the optimal treatment to give to our recurrent thyroid cancer patients. Which question one that I had there was which patients are likely to experience the recurrence, and that is based on the initial risk of recurrence categories. So ATA has classified this previously and now again into 3 different sort of columns, and those correspond to the first column, PTC and its subtypes, follicular thyroid cancer in the middle, and oncocytic thyroid carcinoma, Hürthle cell carcinoma on the right. So I want to use PTC as an example of this and just highlight the 4 different tiers of risk profiles that the patients may have, starting with low to low, intermediate, high, and finally high risk of recurrence, which are based on the histopathologic parameters or the TNM staging. So, for example, bilateral PTC, which is larger than 1 centimeter, would score as an intermediate high risk for recurrence, with about 16 to 30% of that occurring in the future. In contrast, unilateral but multifocal PTC with 6 lymph nodes positive in the central compartment would be low to intermediate, and finally, a very angioinvasive follicular thyroid cancer with more than 4 vessels involved will be, of course, at a high risk for recurrence. So we use this initial assessment to decide whether or not to RAI our patients. And of course, for high-risk patients, with the high-risk features that are listed there, we recommend the RAI is indicated at a higher dose, as opposed to, for example, low to intermediate risk patients where we can consider RAI just with an ablative intent to reduce the remnant sort of thyroid tissue. And for low-risk patients, RAI, of course, is not indicated. So having done that, we can then, having done an appropriate initial treatment for our patients with surgery and adjuvant RAI, we can then decide how do we identify recurrence, and that is on follow-up. So again, we go back to this data framework, and we have diagnosis, our initial assessment of risk of recurrence is plus RAI, and we continue the patients on TSS suppression with levothyroxine. And then we go on to the second A, which is assessment of the treatment response, to come up with this dynamic or cyclical risk stratification. So the assessment of treatment response, first of all, what is the timing? No sooner than 3 months following surgery, because we want to give the patient and his physiology to allow for the thyroglobulin to stabilize following the ablative treatment. And even 6 to 12 months following the initial treatment is acceptable for low to moderate risk disease. The treatment response can be further classified in three different types. One is a biochemical incomplete response, another one is structural incomplete response. And I'll talk about that later, sorry. But here I want to talk about the different ways in which we assess the response. So the first one is biochemical, by trending the thyroglobulin profile, as well as thyroglobulin antibodies, and ensuring that the TSH is at the correct suppressed level. Structurally, we assess the patients as usual using our ultrasound, as well as cross-sectional imaging for suspicious ultrasound findings or rising TG trend. And finally, functional imaging with RAI, whole body scan, or with FDG PET, especially for radioactive resistant disease, or if TG is high and the patient is otherwise RA negative, for IRA refractory disease. That's the word I was looking for. So the disease response can be further subdivided into 3 different subtypes. Of course, excellent responses is what we look forward to. So there's no evidence of persistent or recurrent disease, either biochemically or on imaging studies. Or the response can be incomplete, and the first subtype is biochemically incomplete response. So if a patient is with a suppressed TSH exhibits a TG thyroglobulin of more than 1 milligram per milliliter, that is considered a biochemically incomplete response. In contrast, after TSH stimulation, if the TG rises to more than 10 nanograms, or if the patient has antibodies and the TG trend itself is unreliable, and we rely on following the rising TG-AD trend. So this is usually confirmed by repeating. We don't just rely on a single measurement, and we repeat this measurement usually in about 3 to 6 months, and of course exclude any structural recurrence of disease by doing anatomical studies. And of note, the patient must be compliant to the suppression such that the TSH level is such so as to prevent any thyroid from about 20 to 50% of the patients with incomplete response to progress to develop structural recurrence. So structural and complete response or structural recurrence, of course, is one that's proven by an objective clinical or radiologic disease. This can be either on an anatomical or a functional scan, and it's regardless of the TG or TG-AD levels. Of those patients, they will not do so well. 70 to 85% are thought to progress to persistent or further progressive disease. In contrast, about 10 to 15% will achieve no evidence of disease following appropriate therapy and then go back to routine surveillance. And whenever there's this classification of good, bad, there's always the intermediate, right? So this is the indeterminate response, where the parameters are borderline biochemically and the structural findings are equivocal. So it's not quite clear whether the patient falls under biochemical incomplete response or structural incomplete response, and this is where some of the discussion comes in. So this is where I guess we have to talk more to decide how to treat these patients. So having done the initial diagnosis and assessment of risk of recurrence, followed by the treatment response classification, then we can arrive, and again, for the assessment of risk of recurrence for our patient after the treatment. So for example, if I started out with a patient with an intermediate to high risk of recurrence after initial histopathology, who then had an intermediate response to treatment, that confers about 5 to 20% of recurrence subsequently. And again, this data is all taken from the 2025 guidelines, and I encourage you to use that to treat your patients. So by looking and devising this kind of chart, you can then create your own decision matrix, which ranges from patients who have had low risk to begin with and an excellent response in the left top corner, all the way down to patients who started out with a high risk and then have a poor response to the initial therapy, and subsequently treat them accordingly. So I've created sort of answers for all of these different scenarios, but I will not go through all of them in the interest of time. So, but just wanted to create a few highlights. So, low-risk patient excellent disease requires routine follow-up, with very sort of sparring testing as any and no intervention required, no RAI and certainly no imaging. A chart which I created for low to intermediate risk patients, and the treatment that is required for them to prevent recurrence is escalating. And then for patients who are in intermediate to high risk, for example, who have had a biochemically incomplete response, this is how we would approach it. So first of all, we want to keep the TSH very suppressed. And then we want to evaluate this patient, given that they have had a rise in the TG or a TG above a threshold value. We want to evaluate with a whole body scan or cross-sectional imaging whether there is any structural disease or not. Provided there's no structural disease, indeed, this patient is in a biochemically incomplete response category. Otherwise, he would go on to resection if that disease is localizable. Therapeutic RAI, if the disease is evidence that recommended, whereas PET-CT should be performed for radioactive iodine refractory disease, after which the patient can be re-evaluated for subsequent risk. And this is the cyclical nature of this data framework, where you do the initial treatment, estimate your risk of recurrence, perform additional treatment, and then go back to re-estimate your risk of recurrence, and always find which field in the decision matrix your patient falls in. So for high-risk patients, again, if you look at the rightmost column, the disease is resection recommended. If resection is not possible, therapeutic RAI of a high dose follows. And then for radioactive RAI refractory disease, we can proceed to external beam therapy with IMRT or even tyrosine kinase inhibitor therapy. We can also consider clinical trials if the patient continues to be structurally incomplete category despite all efforts. So that answers the second question. And the third question, I think, was when should I intervene or maybe not yet? So even though we have structurally incomplete recurrence, we then have to ask ourselves, how bad is this disease and how bad is its recurrence? So based on anatomy, recurrence may occur within the thyroid bed, and there are some size thresholds, those growth thresholds that we use to decide whether surgical intervention is indicated. So for nodules or for disease that reappears in the thyroid bed that's smaller than 10 millimeters in size, actually ATA does not recommend surgical resection until that threshold is met, unless the nodule shows some suspicious features, the TG profile is rising, or the initial pathology was very aggressive. For example, like a hobnail subtype of the original. Ablations are adeno or others can be considered non-surgical candidates. Picking should be performed to clear out disease again if the size threshold is met. So for a single node that's less than 8 millimeters in size, intervention is not what the ATA recommends. Instead, a close surveillance with the subsequent ourselves, patients are not really the findings, which are becoming more and more detailed with better imaging modalities are available to us these days. Finally, but for lateral compartment disease, again, the metastasis must be confirmed with an FN. A progressive symptomatic or threatening function. For example, threatening the airway warrant intervention. So therapeutic RAI for heavy disease, local resection can, especially for symptoms, or systemic therapy if the disease continues to progress, RAI refractory. So we have answered which patients can experience recurrence, how do I identify the recurrence, when should I intervene, when not to intervene. Finally, what is the optimal type of intervention for my patients? So surgery is the cornerstone for surgery for microscopic local regional disease, complemental rather than selective, and is also appropriate for isolated nets, especially in the lungs. Palliative for symptoms of threatened organs like or other, for example, or other symptomatic nodal disease in the neck. This has to be balanced with the risk of morbidity and should always be performed by high surgeons and high volume centers. High volume surgeons in tertiary referral centers. RAI is reserved or recommended for biochemical or structural recurrence, in contrast to surgery, which is of course only for structural recurrence, and reserved for RAI-avid disease by definition. It must be purpose-oriented rather than routine and targets non-resectable disease. For extensive disease with patients who receive multiple RAI treatments, dosimetry-based approaches is important. And RAI has no benefit in a refractory setting, or there is no response after one or two treatments. Then happens, a PET-CT should be performed to assess whether there is progressive disease despite no uptake on the RAI scans. Standard therapies that should be molecularly targeted. The standard of care for progressive RAI refractory disease, they are not for cure. I meant to slow down the progression and reduce symptoms. But I think in the interest of time, I'll skip those and just give you the summary slide, which is this new ATA 2025 data framework for dynamic risk stratification. The risk of recurrence comes from histology, virology, and imaging classified risk therapy. Importantly, small and no recurrence warrants immediate intervention. Surgery remains the mainstay for localized disease, whereas multimodal therapy is for aggressive and RI refractory disease. Multidisciplinary management is paramount, and we have to always think about our patients again. So shared decision making. Every factor that I mentioned so far was a disease factor, was a surgery, was a treatment factor. But how about patient factors? So let's not forget tailor our disease to every patient that sits in front of us. So with that, I would like to thank you for your time, and again invite you to the APTS in 2026 in Singapore. Thank you very much.
I'd like to invite the next person for the talk, Dr. Vijay Agrawal. Will you be speaking on the evolving role of the immunotherapy in locally advanced head and neck squamous cell carcinoma?
MSc, and we're going to talk about the evolving role in curative settings. So historically, when we look at the data, there's a very development happening in the curative setting where we have resectable head and neck cancers, and immunotherapy is now coming in a big way in this group of patients as well. In the significant disease burden, mainly regards to the colon cancer, and the vast majority of our patients present in more advanced stages. So they are locally advanced stage 3 and stage 4 they're commonly present. Current landscape in 2025, HPV is quite common in oropharyngeal cancers. In those patients, there is a move to de-escalation treatment. And in the vast majority of the others, particularly the oral cancer data, the RTO study looked at the role of chemotherapy in the curative setting, and essentially post-operatively concurrent chemo-RT has shown to be better than RT for local control or local regional control, and some benefit in survival. But there's no benefit in induction or neoadjuvant therapy. And similarly, when you look at the EORTC at 231 study, again, combined therapy with concurrent chemoradiation is shown to be better in the adjuvant setting, and with improvement in both PFS as well. So one of those which looked at giving 2 cycles of TPF prior to surgery and showed absolutely no benefit at all. The McKinsey analysis, I think we all look at McKinsey analysis, and multiple of those analyses have been done. Essentially, the role of chemotherapy is in terms of concurrent chemotherapy rather than adjuvant or induction on the. If you look at treatment, until immunotherapy came along, particularly in the metastatic setting with the Keynote 048 data, there has virtually been no significant benefit in drug treatment for metastatic or early head and neck squamous cell carcinomas. Various other immunotherapy trials have been done looking at locally advanced head and neck squamous cell carcinoma. Most of them are in combination with chemoradiation or radiation. Been negative, with really no established immunotherapy protocols in the early or locally advanced head and neck squamous cell carcinomas. So the current treatment, essentially the mainstay of treatment continues to be surgery, followed by radiation or chemoradiation, or radiation alone if they are not resectable, or if you are looking at organ preservation protocol. And that really hasn't changed for a significant period of time, for more than a decade or so. So this is the clinical decision flow for locally advanced head and neck squamous cell carcinoma. If it's localized disease, particularly stage 1 and 2, we go straight for surgery plus minus radiation as per indication. Very rarely we give induction chemotherapy in stage 3 and 4, more as if someone's got a borderline resectable tumor and we want to try to downstage that. But if they are resectable, they have to go for resection. If not, then chemoradiation. And if they have been resected, we subsequently give adjuvant radiation or concurrent chemoradiation. And that's essentially been the mainstay of treatment. Even the role of other adjuvant therapies, systemic therapies, has not really established itself in this setting. Neoadjuvant immunotherapy does play a role in various other tumor types, more in terms of sensitizing the tumor cells to the role of immunotherapy. So the concept is that the adjuvant does not work on its own very well, but the neoadjuvant does, because there is tumor in situ, so there are memory cells that are created, and that has really showed itself of some benefit in breast cancers and in lung cancers. And the clue is to take it from them to see if we can get a similar benefit in head and neck cancers. Because so far, most of the trials that have been done are more in the adjuvant rather than the neoadjuvant. As well, this was a study looking at neoadjuvant adjuvant immunotherapy, which is pembrolizumab to improve our eligibility constitution 0 to 1, and patients should have tissue for PD-L1 testing. Stratified based on their primary tumor site, so oropharynx versus oropharynx and oral cavity is one group versus hypopharynx. They were also stratified based on the tumor stage, whether stage 3 or 4A, and PD-L1 testing based on TPS scoring more than 50% or less than 50%. Patients underwent 1:1 randomization, where half the number of patients received 2 cycles of neoadjuvant pembrolizumab alone without any chemotherapy or radiation, and the other half went straight to surgery. And the patients who received the pembro went on to surgery after receiving the second cycle of pembrolizumab about 3 weeks later. So that was the kind of neoadjuvant phase. Post-surgery, patients went on to have the standard treatment, which was radiation plus minus cisplatin, depending upon the risk factors or the need for cisplatin. But in the experimental arm, went on to have the addition of pembrolizumab for 3 more cycles, along with radiation, followed by 12 cycles to complete a 1 full year of pembrolizumab. So essentially, patients received 17 cycles of pembrolizumab, including neoadjuvant and the adjuvant phase. The primary endpoint of this study was event-free survival, and there were various other secondary endpoints such as major pathological response, as well as overall survival, and of course safety as well. When we look at the study treatment details, the radiation dose was pretty much defined. The patients had low risk went on to receive 60 grays in 30 fractions. High risk went on to receive 66 grays in 33 fractions. Ended up with gross vesicular disease. They could go as high as 70 grays in 35 fractions. That was in both the groups of patients. Patients went on to receive if they were high risk or had gross vesicular disease, which is 100 milligrams per meter square every 3 weeks for 3 doses. What was defined as a high risk was positive margins, so margin less than 1 millimeters, and extranodal extension, which was the typical indications for receiving cisplatin. The baseline characteristics were equally balanced across both the groups of patients. The majority of the patients had oral cavity tumors, which is about 60% of the patients, followed by laryngeal tumors. And if patients had oropharyngeal tumors, the HPV status was also evaluated, and only a small minority of them were HPV positive. PD-L1 was tested in all of those group of patients, and they were well balanced in both the groups. But if you look at the PD-L1 right at the bottom here, you see that 95% of the patients had PD-L1 positivity of some state. So essentially, this was a study you could argue was in PD-L1 positive patients, because 95% of them had PD-L1 positivity of at least 1 or more percent. So when you look at the treatment disposition, I think one of the biggest fear with us is that if you're going to delay treatment by 5 to 6 weeks by giving 2 cycles of neoadjuvant pembrolizumab, are you going to miss the window of opportunity to operate if they do progress and disservice some of the patients? And this was quite clear in this that in both the groups of the patients, about 88% of them underwent surgery, with equal in both the groups. I think that fear is ameliorated, thinking that if we delay treatment by about 5 to 6 weeks, are we going to miss the opportunity to operate on this group of patients? The other important thing I would like to highlight is the number of high-risk patients in both the groups. So the high-risk features were present was less in the pembrolizumab group as opposed to the standard of care group. So 44% to standard of care went down to 32% in the pembrolizumab or experimental group, essentially saying that 2 cycles of neoadjuvant therapy could actually downstage some of these patients. And of course, the number of low-risk patients proportionally went up from 42% in standard of care to 54%. So you could downstage some of these patients. And the resultant outcome of downstaging some of these patients is if you go further down to number of patients who are taking cisplatin was much less in the experimental arm as opposed to the standard of care arm. So you could technically avoid or reduce the number of patients who required concurrent cisplatin along with radiation if you gave them 2 cycles of neoadjuvant pembrolizumab, which I'm sure a lot of patients might prefer. And when you start looking at the dosages of radiation as well between the two arms, the patients in the experimental arm received an average of 60 grays as opposed to 66 grays in the standard of care arm. So what I'm trying to illustrate is that 2 cycles of neoadjuvant immunotherapy downstage a lot of these patients, so you end up giving them less radiation and less chemotherapy as a group in totality. Now, coming to the main primary endpoint, which was event-free survival, it was first looked at those patients with a PD-L1 score of more than 10%, and we can clearly see the benefit was seen in the experimental arm in favor of those patients who went on to receive neoadjuvant and adjuvant pembrolizumab. When we look at the median event-free survival, 59 months versus 27 months in favor of the experimental arm. So more than 20 months difference between the two. With we see a similar picture, 59 months versus 29 months with a hazard ratio of 0.7. And when we look at intention treat patients, and these intention treat patients, you see a similar number of 51 months versus 30 months with a hazard ratio of 0.73. So the benefit was same for all patient population, more than 1% CPS scoring as well as more than 10% CPS scoring. For all intent and purpose, I think all participants, probably the outcome is mute because 95% of the patients had a PD positivity of 1% or more. When we look at this, was very, very small, so very difficult to this particular subsection, but essentially for all of them, the benefit was seen, irrespective of the tumor stage, tumor location, as well as smoking status. We already discussed a little bit about this, the radiation exposure pathological subgroups. The patients in the experimental arm, which was the ones that received pembrolizumab, the number of radiation given was much less compared to both in the low risk as well, both in the low risk as well as the high risk. When you look at the low risk group as well as the high risk group, both the groups benefited by pembrolizumab addition to their standard of care. And even when we look at the major pathological response, which is one of the important key secondary endpoints, was much higher in those patients who had about 13% in PD-L1 more than 10%. And 10% of patients in PD-L1 more than 10% of all participants had a major pathological response. A major pathological response was defined as less than 10% of viral disease at the end of surgery. Key secondary endpoint was again overall survival. Overall survival, the trend was there in favor of the experimental arm with the pembrolizumab. I think we still have to kind of confirm, but the trend is there with a hazard ratio of 0.72. So one of the concerns that people would have is the reason surgery was not performed in about 12% of the patients. Even though it was equal in both the groups of patients, I think main concern, which was disease progression, was only in a small number of patients. If you look at progressive disease here, only about 4% of the patients had disease progression, which is a small minority of them as compared to the rest of them who did not have disease progression. So surgery could not be done in those group of patients, and presumably most of them went on to receive chemoradiation. When you look at the surgical outcome, R0 resection was performed in the majority of these patients in both the groups of patients. Toxicity, not really much to talk about. There was no significant increase in the toxicity in the experimental arm that contained pembrolizumab, both grade 1 and 2 versus grade 3 and 4. So not much significant increase in toxicity. And when we look at the immune-mediated adverse events, slight increase in those patients who received the experimental therapy of pembrolizumab, but most of these increase was in grade 1 and 2 rather than grade 3 and 4. Essentially, the summary of safety, which essentially says that there was not much difference between the two, and not something that we were not aware of. The study also evaluated patient-reported outcomes using the EORTC quality of life data, both the C30 and the head and neck 35 scoring for pain, swallowing, and speech scores, and essentially showed that there was not much change in the quality of life between both the groups of patients. When we look at the QLQC 30 scoring and for both the arms, essentially across quality of life as well as physical functioning. In fact, when you look at the head and neck 35 scoring, there was slightly better reduction in those patients who went on to receive neoadjuvant immunotherapy, particularly towards the end of their radiation, which is kind of here. You see better reduction of pain in the experimental arm as opposed to the standard of care. So again, changing baseline, not much between the two arms, so not much to kind of speak about. So essentially, the quality of life was equivalent in both the subgroups of patients. A small improvement of 10 points in the head and neck 35 pain scores, but otherwise similar in both the arms. Based on this, global approvals have been received for pembrolizumab both in the neoadjuvant or adjuvant settings, a perioperative setting, 2 cycles of neoadjuvant immunotherapy followed by surgery and then adjuvant immunotherapy in all patients with head and neck squamous cell carcinomas with stage 3 and 4, so locally advanced stage 3 and 4. And both of them did say that the approval was there only for PDL1 more than 1%. So patients had a CPS score of more than 1% because essentially the study, 95% of these patients had a PDL1 of more than 1. Based on this, the NCCN also approved it for those patients who have locally advanced head and neck squamous cell carcinoma stage 3 and 4A with a PDL1 CPS scoring of more than 1. So this is now going to be standard of care worldwide, both in Europe and US. We in India are still waiting for the CGA approval, and as and when we get that, we should hopefully become standard of care in our practice as well. That is it from me. I'm quite happy to take any questions.
Thank you so much. Any questions? Floor mic.
Lovely talk.
Thank you.
Was there any discussion about the margins of surgery after the neoadjuvant pembro? Any change based upon the residual induration, or was it the initial margins only?
It was the initial margins, and there was, if you look at between both the arms, it was pretty much equal in both sides. There was no downstaging of the margins, so to speak. I don't think they specifically mentioned that part. But when you look at the margins between both of them, there is not much difference. Yes, please. Yes, ma'am. Thank you.
I think the advantage of the 30-month advantage of the event-free survival is not something to be utilized. On the other hand, I'm just curious to know what happened to the patients who failed. So did they also receive immunotherapy? Because the concern really is that are we over-treating by giving everyone immuno? Would the impact on overall survival be the same if we were to introduce these patients were to fail is something that comes to mind.
So they haven't given post-treatment treatment details in this. So the patients who did progress, would they continue to receive therapy post-operation? Those details are not in the NGM field. I suspect not, because even in the adjuvant setting, we wouldn't continue with that.
I meant in the control arm. It's a control arm. If patients fail crossover, did they cross over to immunotherapy?
They haven't mentioned that, but the presumption would be that if they progress, they'll be out of the study, and we would give them immunotherapy.
That would in some ways be a concern. Is it that we are perhaps over-treating patients who would not otherwise require? Having said that, I think we can't discount the event-free survival as well as the fact that certain number of patients did not meet cisplatin. I think 60 and 66 is not very different from the patient point of view, but cisplatin.
Yes.
So for stage 3, then chances of metastasis will be less in those patients other than stage 4 patients.
So are we over treating stage 3 patients by giving immunotherapy non-patient?
So we are clearly seeing a significant difference in the event-free survival.
Yeah, event-free survival, but the main difference is in metastasis, not local relapse.
Correct.
That was not significant.
Correct.
So because we know stage 4 risk of metastasis will be more in those patients. So stage 3, when risk of metastasis is not that much, so are we over treating stage 3 patients?
So we'll have to wait for the OVAS data, like Madam Arvind said, the lack or the reduction in the distant metastasis, will that impact on the overall survival itself?
Okay. If there are no more questions, what is the effect of pembrolizumab on the tumor tissue, the surrounding tissue, and what do you find intraoperatively? Are there any
So
analysis on that?
if you look at the major pathological response rate was quite high. It was about 10 to 13%, depending upon which CPS scoring subpopulation they were. Okay, but there is clearly an margin or not is difficult to say, but there's no mention of that on the.
The session is running late. We'll move to the next session. Thank you very much.
Next, we have the panel session on recurrent metastatic head and neck cancer. So, to chair the session, I would like to invite Dr. Amir Saifee. Let's invite all the panelists, Dr. Bharat R. Dr. Kinjal Shankar Majumdar, Dr. Kirti Kaushik, Dr. Manish Goswami, Dr. Narayan Subramaniam, Dr. Rakesh Katna, Dr. Shekhar Patel, Dr. Swagnik Chakrabarti, and Dr. Tanvi Shah. Request all the panelists on the stage.
Tanvi is not coming. So we will be having only one radiation. So you will have all the responsibility from the cases. A very good morning, everyone. I would like to thank organizers for giving me this opportunity to moderate this panel, different metastatic head and neck cancer. So we have more of head and neck surgeons panel. So majority of them are head and neck surgeons. So more about surgical aspects. We know around 30 to 40% of all our head and neck are going to have recurrence or metastasis after treatment. And once patient recurs, then we know outcome is poor. Salvage treatment is possible due to better surgical and radiation techniques, and advances in immunotherapy and targeted therapy has shifted the paradigm in management of these cancers. So there should be emphasis on multidisciplinary care, and careful selection of patients with recurrence is crux of successful management. So salvage treatment is a challenge because this is mainly considered for localized recurrence. So, and treatment is constrained by previous therapy like surgery, radiation, or chemoradiation. Salvage modalities are associated with considerable morbidity. Reconstructions and quality of life issues are there due to prior treatment, and there is poor evidence base to support management options in these patients. So if any patient comes to your OPD, what questions will come to your mind? Yeah, start from there, because after radiation, patient will come to you. So if patient comes with recurrence, what questions you are going to ask yourself?
So basically, if the patient comes back with recurrence, we always look at where is the site of recurrence, how long it has been since the therapy has been completed. Then was he on constant follow-up? Was he continuing his habits in terms of if it is tobacco associated? Then we see whether it is localized or it is regional or it is metastatic, or ECOG status means if his performance is good or bad. Then we decide on further therapies based on his previous treatment, his general condition, and also the type of recurrence and the disease-free interval. These are the major questions which we always ponder upon to decide on further treatment.
Yes, so at that point of time, you decide whether we are going to salvage this patient or whether patient is going for palliative treatment. So then salvage is
I would
possible.
like
Yeah.
to add one point. We have to also consider the patient issues. How motivated the patient is, what was the previous treatment, what is the associated toxicity right now. A patient might be salvageable, but we also have to look whether the patient is ready to undergo any further treatment. And that factor ultimately becomes the decisive factor in avoiding treatment.
Yeah, so most important thing is, even if we think we can salvage this patient, salvage this tumor, but the patient choice. So sometimes even a small recurrence patient will say, I don't want the treatment, just leave me alone. So whatever is there, I have to go through this one. So the patient choice is also very, very important for deciding further treatment in these patients. So median survival, if you see, this is 2013 data. So if these patients are untreated, you can see that median survival is very less, around 4 months. If surgery is included with adjuvant treatment, then it is almost 20 to 22 months. And for re-radiation and systemic treatment, it's around 8 to 12 months. So this is 2013 data, maybe 2025. With the advent of all targeted and immunotherapy, that might have changed, but this used to be previously. So site wise, if you see, so which site you would like to salvage? Narayan.
So I think all patients.
Oral cavity, larynx, pharynx, neck thickness.
So if I had to choose, larynx would be the best. The T1 blood test with pharynx salvage has the highest cure rates. But I think, like everybody said, it's important to realize number one, is the patient curable? What is the patient's performance status? And we really have to differentiate between residual and recurrent disease, especially in oral cavity. If it's disease that's been left behind, gross residual disease, and then irradiated, results are usually very poor, prognosis very poor. Residual disease that comes back when it's focal, when the patient has a good performance status, we have the ability to consolidate with further treatment, we would choose surgery.
Yeah, so larynx has the best salvage rate and neck has the worst survival. So oral cavity and pharynx comes in between. And stage wise, if you see, stage 1 and stage 2, survival is almost 2 years, survival is almost 80%. And once the stage advances, for stage 4, it comes down to almost 20%, 20 to 30%. So selecting patients with advanced stage recurrence, we have to be very selective in these patients, because otherwise patient's quality of life is going to suffer. So decision for what are the points you will consider before taking up for salary? Sorry. Yeah, Kinjal, yeah, go on.
I think the points are well made by my previous colleague. So mostly, first will be the performance status, obviously, as the patient presents to me. Second will be the previous treatment details. As a surgeon, I would additionally, if it's surgically salvageable, I would obviously look for the what are the surgery or what are the exact surgical details in the previous surgery. Then the third point, obviously, the stage at which the patient presented to you?
Yeah, so what are the all positive points that will help, like that will be positive for survival in these patients?
Localized recurrence, first, good performance status, and obviously early stage recurrence.
Yeah, so early stage, if it is there, so obviously because these patients will have better survival after your salvage, so these points we have to consider for our salvage. So we will come straight to the case. So this is a 55 years old male patient, post-op case of CA left buccal mucosa, T3N0 MGO. Patient was operated in another hospital. All margins were free, but superior margin was closed. That was around 2 millimeter. He was planned for radiation, but he developed growth in the operated side. At the superior, you can see the pictures. This was on the superior aspect of your flap. So PET CT showed localized recurrence with one node left level 3. So what next? Biopsy is again, that is obviously this is positive.
So we have a very low DFI, but again, said margin was also very close. So if it's a localized thing, no IKF and a single node, I think we should better go for resection with wide margins, put in a flap and plan adjuvant therapy.
So if patient, because already you have seen the patient, so would you like to go with chemoradiation or radiation, or you will refer back to surgery?
Back to surgery.
Why not? Because chemoradiation.
So probably we will call it as, though we say that it's negative margin, close margin. I feel there was some disease which was left behind because of itch only. Probably it's more of residual.
Usually,
Because it was 2 millimeter, and with this kind of disease, tumor coming back in 4-5 weeks, that means disease was aggressive.
And radiation is effective in oral cavity, especially when it is microscopic, means when there is no disease. If we try to do this, it's not going to give good results.
Yeah,
I think the accepted timeline is generally 3 months for residual disease. So this is clearly residual disease.
no, but sometimes you see in your clinic,
I completely
sometimes
agree.
because tumor is so aggressive, that can come very fast.
Completely agree, but we should treat it as residual disease, and when there's gross disease there, chemoradiation is not the answer.
Yeah, because this surgery was done by oncosurgeon only, so I can think, okay, he would have taken adequate margin before giving surgery.
So looking at the clinical picture, I think with the amount of fungation that the patient has got, it is very unlikely that the patient will be taken up for radiation anyways. Probably chemoradiation we are ruling out immediately. Reassessment and probably
So
consideration.
if patient requires resection, are you going to do resection immediately, or you would like to have some NACT or something, so that, because we know this is aggressive disease, this is not simple, okay, left buccal mucosa that you have operated. Tumor is coming.
Can I just add one point? So what we are also missing here is that patient has come back with a neck node also.
Yeah.
So you have a disease localized recurrence, maybe because of the closed margin, that is our one theory, but he has gotten a node also. So that definitely this is a very aggressive disease.
Yeah.
And it is done by an expert oncosurgeon. Within 5 to 6 weeks, if it's getting the tumor biology is really bad.
Yeah.
So I will not consider this patient for surgery immediately. Then probably we'll go for chemotherapy and then see the response stabilizes, and then post maybe next I will consider for surgery later.
Okay, Dr. Patil.
I agree totally, because if you look at the biology of the disease, if you operate him, you may not get. If you look at the biology, recurrence risk is quite high. Better to go for some neoadjuvant therapy, downstage it, see how it behaves, and then go for surgery may be a good idea. You may attend even to the microscopic diseases.
Yeah, Dr. Shilpa, yeah.
Rajiv, what I would like to say is we have like 2 sets of patients coming like this, very early recurrences.
Yeah.
And looking at this particular patient, it doesn't look like a truly aggressive tumor. And it's a technical miss, I would say.
No, but you can see that kind of growth in 4-5 days, because
So
nobody is going to leave disease if he is going to do free flap reconstruction, because patient has undergone free
No,
flap.
I think we cannot say that nobody is going to leave disease. That's
Okay.
technical. So
So
what I am trying to make this point is, we also need to look into the histology. So there are truly aggressive ones where we see the the adverse pathological features,